I am Dr. Kristen Lindgren from Lindgren Functional Medicine. As you may have noticed, I am not in my usual loft set. We are planning on building a set. This is not it, but it is a, somewhat quieter office in the building with kind of bad lighting. So we're just going to see how things go. And I'm done with the hair, so it's up. If you hate it, well, that's fine with me. If you've seen any of my other posts, you know that I always write down what I'm going to say before I say it. Many moons ago, I attempted to shoot from the hip on topics, and, well, that went terribly. Well, I thought it did anyway. I think I'm a relatively good speaker, but I have a tendency to ramble when there is a camera in my face, particularly when I'm asked to cover a dense subject cohesively. Try it. You'll probably do the same. Lots of ums and uhs. That probably immediately disqualifies me for politics. You see what's happening? I'm already derailing. But I have this secret edit button. We might be using that. Regardless, this one we're doing mostly unscripted. And we'll just see how it goes. Remember, I am just a human. So, be kind to me in the comment section, please. And thank you very much. Okay, here we go. I had a really nice conversation with a patient last week, and she was the one that recommended that I do this episode, which I am going to title What a Cancer Journey Looks Like at Lindgren Functional Medicine. She thought that the whole process was rather confusing and was very appreciative of me kind of just walking through that with her, and thought that others would appreciate the same. And so we're going to see how that goes. I have given myself some talking points to hopefully prevent myself from derailing from medicine and, end up talking about aliens. I do want to start with a brief opening statement that I did write before getting to the talking points. So here it is. I don't know that there is a more frightening statement a person can hear from a physician than "you have cancer." I remember being in medical school and thinking about getting cancer myself and how I would deal with simply knowing that even if they could cut it out, there would always be cells left behind. And how could I go on with life just waiting for those cells to come back and kill me? I distinctly remember the dates and times I learned that both of my parents were diagnosed with cancer, and wondered the same thing. If we can somehow make it through the first part of this journey, how will we keep it from coming back? As many of you know, my father did not make it to remission and passed away in 2021. The conventional care model feels unsettling for many patients. I joke, only half joking, that outside of surgical or emergency care, medicine no longer needs doctors. They need kiosks. You just walk up to the kiosk with your identification and insurance cards, tell the kiosk what your symptoms are, and the algorithm the kiosk is trained on will tell you what needs to be done. Maybe that's a chest x-ray, an antibiotic, a CAT scan. In oncology, the treatment of cancer is also based on an algorithm. That algorithm is based on what science supported at the time the algorithm was written, probably 2 decades ago or more, and what your insurance is willing to pay for. For example, let's say I'm a 50-year-old female with breast cancer. I turn 50 this week. None of you are allowed to tell anyone. The algorithm determines whether I get chemo before or after surgery, what kind of chemotherapy is best for my cancer, and which ones my insurance will cover, what my surgical options are, if I need radiation and how much, do I or do I not need hormone-blocking medication and for how long. It determines what kind of imaging or whole body staging I will receive, what my follow-up schedule looks like. If I'm lucky enough, at some point, the oncology algorithm will say, "Congratulations, Kristen, you have no evidence of disease." And I say, "Really? How do you know?" "Well, We can't see anything on your scans anymore. You're good. Well, that's awesome. Okay, well, when do I need to come back? Once a year, twice a year, for a few years, and then you're done. You don't need to see us again. Well, until your cancer comes back, of course. Wait, what? I thought my cancer was gone. Remember? No evidence of disease? Well, you had your breasts removed, so it probably won't come back there. It will most likely be in your liver, your kidneys, or your bones. You know, stage 4. Well, how would I know if that happens? What can I do to prevent it from coming back? This is many of our patients. They feel fear. They feel overwhelmed. They've already endured the diagnosis of and treatment for cancer. They want to do something. They want to be proactive to keep it from coming back. They don't know where to turn or who to ask. This is often when patients find us. Talking point number 1. What can Lindgren Functional Medicine do for my cancer? Okay, well, lots. I'll start here. Other countries that are far more advanced in cancer diagnostics and treatment track many next generation metrics in addition to the standard labs and imaging studies we use here in the US. You've heard me talk about RGCC, or the Research Genetics Cancer Center in Greece, which has a whole menu of very advanced labs that help better quantify what is going on with someone's cancer at the cellular level. In simplified terms, they offer liquid biopsy or blood testing, which can detect cancer cells before they are able to be seen as a tumor on a CAT scan, as well as residual cells that are left behind following conventional cancer treatment. We call these CTCs, or circulating tumor cells. Science tells us in general that cancerous tumors are formed about 8 to 10 years after these CTCs are found floating around in circulation. It takes them many, many years to multiply and divide enough to cause a measurable mass or be detected on an imaging study. CTCs are a signal, not a sentence. They do not represent tumor burden or what we see on imaging. Both pieces of information are valuable, and they both have their advantages and limitations. Depending on how long I end up going with this, to answer the question directly, what can Lindgren Functional Medicine do for my cancer? We can offer advanced testing that just isn't available yet here in the US. Alternative treatments, including repurposed drugs, natural substances, high-dose intravenous vitamin C, supportive oligonucleotide therapy, or SOT, which is now called Q-restraint therapy, mistletoe, peptides, hyperbaric oxygen therapy, dietary and lifestyle interventions. Besides what you may have been told, there is much you can do outside of conventional cut, kill, radiate for treating cancer. Talking point number 2. Why doesn't my oncologist know about circulating tumor cells, or CTCs? Because your doctor wasn't trained in a country that had this technology, and the algorithm conventional oncology follows doesn't use this testing. Oncologists know that we can cut cancer out, we can radiate it, treat it with chemotherapy, but that cancer comes back because of these cells that are left behind. That's why we do this next generation testing from RGCC. Greece is about 30 years ahead of the US as it pertains to cancer diagnostics and treatment. We use many of their liquid biopsy tests to monitor for, diagnose, and make treatment recommendations for cancer. They have 2 tests that we use very frequently. One is called the OncoTrace. The other is called the Onconomics. Those are 2 of many of their tests. Both of those tests give us a number of circulating tumor cells, or CTCs, per blood volume, and cancer stem cells, or CSCs, which are a subtype of the circulating tumor cells. When cancer comes back, The cancer stem cells are the most resistant to treatment. When cancer returns, even if it's been gone for decades, it's because of those cancer stem cells. They are, again, just very treatment resistant. We don't use either of those numbers in isolation. Those tests don't take the place of your other labs, inflammatory markers, imaging studies. In our practice, we use this testing in addition to conventional testing because it helps us to understand how a person's cancer is behaving, how aggressive it looks, and how hard we need to go after it. Left to its own devices, cancer wants to do one thing and one thing only, and that's to grow. That CTC number wants to go up. Our aim is to drive it down. Many of our patients with cancer have had this testing done, and they are told what their CTC count is. It's often a number like 2, 2.8, 3.7. We try to get that number as close to 0 as possible. In my experience with RGCC, once the CTC count is less than 2, we've got a pretty good handle on the cancer. Once it's less than 0.4, we consider that the equivalent of no evidence of disease at the cellular level. I have not had patients drive their CTC counts down to 0 yet, but many of my RGCC colleagues have. And this can take a long time. How long? People hate this answer, but it's true. It totally depends on the patient. If you've met one patient with cancer, you've met one patient with cancer. One provider I work with through RGCC had a patient with prostate cancer that took 12 years to get his CTC count less than 0.4. By the time a cell has become cancerous, it is already a wizard at dividing and invading other tissues. Cancer cells want badly to increase, not decrease. With intervention, we expect CTC counts will be stable or trend downwards. Even if they tick up a bit, this does not mean a patient is failing. It can mean that we need to reevaluate our treatment plan. It can also mean we simply need to stay on course and give it more time. We use many different metrics in conjunction with the patient's clinical condition to make that decision. Talking point number 3. How long do I have to take all this crap? As I mentioned earlier, one of the extremely useful tests offered by RGCC is called the Onconomics Extracts Plus test. There are 2 parts to this test. One tells us about the transcriptomics or genetic behavior of a cancer. The other tells us which natural substances have been demonstrated to be effective in treating that specific cancer. So we use that test on a number of levels, but what patients end up seeing is usually more of the second part. So when I'm developing a management plan, I use that test to help guide recommendations for supplements and medications for each patient's individual cancer. Based on the onconomics results, I personally put together a treatment protocol of 3 supplements that we change up every 1 to 3 months, depending on the genetics. We keep an eye on how things are going by monitoring standard blood tests, sometimes imaging studies, and repeating the OncoTrace test every 3 to 4 months. The onconomics is an awesome test, but it has some limitations. For example, in that second part of the test, they take circulating tumor cells and expose them to 1 dose of a natural substance or medication. Let's say that's vitamin C. 48 hours later, they look to see what percentage of those cancer cells died, and they report that number out on the test. But many natural substances don't work by just giving 1 dose. They need to be titrated up. They need to be given in a pulsatile fashion. They need to be taken in conjunction with other therapies like fasting or hyperbaric oxygen therapy. Or they simply work by not directly killing cancer cells. They work to help support the immune system. So even if vitamin C, for example, doesn't flag as being, quote, effective on the second part of the onconomics test, it doesn't mean that we wouldn't necessarily recommend that for someone's cancer. So when I make a treatment recommendation based on the onconomics results, it can, in fact, look like a whole pile of crap that I would like a patient to be taking, because I know the limitations of the test and how natural substances and repurposed medications can work for cancer. Again, even if they're not on the onconomics tests, often I recommend them anyway. So it can understandably look like a lot of stuff. It's not crap, but you know what I mean. Supplements are not meant to be a punishment. They don't make a person morally superior either. They are not forever. They are a means to an end. And the end can be a year from now, or it could be 10 years from now. Again, everyone responds differently. Some people love taking supplements. Other people hate them. A supplement regimen can be mentally exhausting, and I completely understand that. You are not a bad person if you simply cannot swallow 30 or 40 pills in a day. We meet every patient where they're at. Anything you can do is better than doing nothing at all. Do what you can afford to do. Swallow what your brain will allow you to. You are the patient, and you are in the driver's seat. We work for you. This is your time, your money, your resources, and I respect that everyone has limitations. When I put together a treatment plan, it is based on my personal bias of being as aggressive as humanly possible. So just understand that. Talking point number 4. So what are my options? Okay, lots. I listed many of them above, but I want to go back to first, SOT or Q restrain is hands down the most powerful targeted therapy we have for treating cancer. I have a dedicated post to Q restrain, which I will link below, as to not rehash all of the intricacies of that here. But in short, Q restrain, formerly known as SOT, is a piece of genetic Velcro material. It's not actually Velcro. This is just the analogy I use for patients. Made by RGCC for your unique cancer type that is administered 3 times in year 1, so every 4 months, and twice yearly thereafter, that binds to and prevents your specific cancer cells from dividing. So when they make these Q restrains, they sequence out your individual cancer. They find the section that's responsible for cell division, and they make a mirror image of it, if that makes sense. So when we give that infusion, that piece of genetic material is so small. It's so small. It doesn't matter where that cancer cell is. It will find it. And it can only bind to that sequence. And when the cancer cell goes to divide, it gets hung up there and can't divide, thus triggering what we call apoptosis or programmed cell death. So you could make a Q restrain for, let's say, person A's cancer, but give it to person B's cancer, it would do nothing. This is technically genetic material, but it is not mRNA or DNA material. It is totally synthesized. These are called antisense infusions that, again, stop your specific cancer cells from dividing. This is not mandatory, and it is not an option in all instances, but it is the most powerful option we have available for patients, especially with early stage cancers. This is not an option for patients who have very large tumor burdens, multiple pulmonary metastases, or lesions in the brain due to the risk of something called tumor lysis syndrome. The schedule of every 4 months, year 1, every 6 months, year after is not mandatory. This is simply what is recommended by RGCC based on their research. Second, output testing. OncoTrace and Onconomics testing are extremely sensitive and useful tests. The OncoTrace testing tells us how many CTCs and cancer stem cells are detectable in circulation. Again, this is a a liquid biopsy or just a blood test. It tells us how those cells are behaving from an aggressiveness standpoint, and often what the tumor of origin is. Not always, but often. We like to do this test as a baseline and then repeat it every 3 to 4 months to see how our interventions are impacting those numbers, along with standard inflammatory labs, tumor markers, imaging studies, and how you, the patient, are feeling. Do we have to do that test every 3 to 4 months? No. All of these tests are out-of-pocket expenses, and who amongst us has unlimited wealth? However, I always like to think of my management plans from the standpoint of, well, if this was me or my family member, what would I recommend for them? And so from that perspective, I recommend follow-up testing with OncoTrace every 3 to 4 months, at least until we can drive those CTC and cancer stem cell numbers down nice and low. Onconomics is a much more expansive and much more costly test than the OncoTrace. It too gives us a read on CTC and the cancer stem cell count, but again, much more information about how those cancer cells are behaving and which natural substances are effective at killing those cells. RGCC offers an even broader test, which looks at chemotherapeutic agents that are most likely to be effective for any given cancer. We rarely order this test for a couple of reasons, the most common of which is the results can be frustrating information to have, because remember, the oncology algorithm is based on typically outdated science, along with your insurance company's willingness to cover that chemotherapy. I realize this is a lot of information. Sometimes that information is empowering, and sometimes it's just interesting, and sometimes it's emotionally annoying. And that's okay. Because again, there's no single right way to walk this path. You as the patient are in the driver's seat. We can do all of it. We can do some of it. We can do some combination of the two. Everyone has different financial and emotional resources, and all of this guides the direction we end up taking. Talking point number 5, why we don't promise outcomes. Let me be very clear about expectations. Science has given us many useful tools for treating cancer, both from the conventional side and the functional side, but not a single solitary one of us has a crystal ball or a magic wand. Science is based on populations of people. We know that interventions are useful when they work for a certain percentage of that population compared to a control group. This should go without saying, but you are not a population of people. You are one person. What works for the population may not work for you, and that goes for any cancer care intervention. At Lindgren Functional Medicine, we don't promise cures. We don't promise that cancer will never come back. And anyone who tells you they can promise that is lying. What we do promise is transparency, honesty, data-driven recommendations, flexibility, and respect for your limits. We use advanced testing to reduce uncertainty, not to create new fear. And sometimes the biggest win is not driving a number to 0, but keeping a number stable, keeping inflammation low, helping to heal damage done by surgery, chemotherapy, or radiation, keeping immune system surveillance strong, and letting you live your life without cancer occupying every waking thought. I want you to live your life to the fullest extent possible, not feeling like crap or taking as much crap as possible. I think we're getting there. Talking point number 6. Living with cancer versus living in fear of cancer. This is an important one. There is a difference between being vigilant and being consumed. You can care deeply about your health without making cancer your entire identity. I tell patients this all the time. Your job is not to beat cancer every day. Your job is to live a life worth protecting. That means eating well, most of the time, moving your body when you feel like you can, sleep, supporting detox, doing infrared sauna and or hyperbaric oxygen therapy. Super exciting news. We just purchased 2 new chambers for the office. We used to have to send people out for hyperbaric therapy, but starting next month, I believe, we'll be able to offer the service in-house. Excited about that. Enjoying your family, traveling, laughing, resting. Cancer treatment is not supposed to feel like a full-time job, although I get it. Sometimes it sure does. Talking point number 7. Why we individualize everything. Well, because everyone is different. Some patients want aggressive testing. Some patients want aggressive treatment, frequent monitoring, every available option. Some patients want one powerful intervention, like Q-restrain. They want minimal supplements, fewer labs, less mental load. Some patients want to do enough, but not do everything. And all of those choices are valid. My role is not to tell you what you must do. My role is to tell you what's possible and then let you choose. Okay, I'm sure that there are more questions, but that's probably enough of my rambling for now. So I'll sign off. So if you're watching this and you are newly diagnosed, in remission but unsettled, scared but functional, overwhelmed by options, exhausted by supplements, or just trying to figure out how to live life after cancer, please hear this. You are not failing. You are not behind. You are not doing it wrong. Cancer care is not black or white. It is not all or nothing. It is not perfection or disaster. Anything you can do is better than nothing at all. And doing less intentionally is sometimes the healthiest choice. At Lindgren Functional Medicine, we meet you where you're at, and we walk with you, not ahead of you, not dragging you, and not judging you. That's what a cancer journey actually looks like here. Thanks for listening. I'll see you all for the next one. Bye for now.